The following surgical training video will show a representative example of a single tooth replacement. All implant cases have many of the same anatomical and surgical parameters that need to be applied whether placing a single implant or placing multiple implants. The most accurate definition of implantology is that it is a prosthetic discipline with a surgical component, rather than a surgical discipline with a prosthetic component. Today's patient demands to have an implant placed in such a position and such an angle as to afford the most ideal prosthetic result. The placement of the implant must conform to a prescribed prosthetic treatment plan. This case shows a missing lower right second bicuspid. The distance between the adjacent teeth is approximately 10 millimeters, and the distance from the crest of the ridge to the superior aspect of the mandibular canal is approximately 14 millimeters. The recommended distance between the side of an implant and the periodontal ligament of the adjacent tooth is approximately 3 millimeters. Therefore, a 4.1 diameter Endopore implant would allow for 3 millimeters of bone between the implant and the adjacent teeth. The safe distance from the apical aspect of the implant and the superior aspect of the mandibular canal will lessen as the surgeon becomes more skilled and more confident. The most important safeguard against violating the canal space is the use of infiltration anesthetic rather than block anesthetic. With infiltration anesthetic, the patient will be able to communicate to the surgeon if any of the instrumentation is too close to the mandibular canal. In this example, with 14 millimeters of bone superior to the canal, there is more than an adequate safety margin for the anticipated 9 millimeter length Endopore implant. As we look at this case from a clinical aspect, we see that the distance between the coronal aspects of the adjacent teeth is ideal for the anticipated crown. Obviously, with the adjacent teeth without restoration, an implant is the treatment of choice. The soft tissue health is ideal. Surgery should not be performed until the overall periodontal health of the patient has been verified. And if the patient is in need of periodontal treatment, that phase of the treatment should be completed prior to the appointment to place the implant. Prior to the beginning of the actual surgery, the surgeon should be thinking and anticipating the surgery from the beginning to the end of the case. One of the most important parts of a surgical case is flap design. The proper incision will set up the case for proper blood supply and proper healing. The incision should be, whenever possible, a crestal incision in keratinized tissue with the anticipation of a full thickness flap. The surgical site is anesthetized using a subperiosteal infiltration technique. A full carpule of anesthetic is placed on the buccal aspect and a full carpule on the lingual aspect. It's very important that the anesthetic be placed subperiosteally so that the surgeon can assure himself that the needle is against the hard tissue before depositing the anesthetic. The incision should be a full thickness incision. Once the incision is completed, the flap is elevated. While there are several types of periosteal elevators available to the surgeon, and to some degree the type of elevator is a matter of personal choice, the Woodson type elevator shown in this video is a very good elevator for the initial release of the surgical flap. Much like the incision was a full thickness incision, the reflection of the flap must be a full thickness reflection. Care should be taken not to tear the flap into layers when reflecting the tissue. It is usually much easier to elevate the lingual aspect of the flap first, and then proceed to the buccal aspect of the flap. You will note that there is very little bleeding present on this video. This is more of a matter of proper flap incision and reflection than it is hemostasis gained by the local anesthetic. Once the flap is elevated, the proposed surgical site is examined for any soft tissue tags that may be present. If there are any of these tags of tissue present, they may be removed using an elevator. Do not use surgical gauze to remove any soft tissue tags. The spicules of bone that are present in any ridge will shred the gauze and might introduce these fibers into the osteotomy.